Hello, ISHA members. Dr. Benjamin Dome here, regrettably coming to you live from a failed connection in Washington, D.C., attempting to get to Cape Town. I hope to see many of you soon. This presentation is on the minimum 10-year outcomes of hip arthroscopy with a retroverted acetabulum. My disclosures are listed with the American Academy of Orthopedic Surgeons. By way of background, acetabular retroversion can be categorized into two main types, focal and global. Focal retroversion refers to localized posterior overcoverage, while global retroversion involves a more extensively posterior-oriented acetabulum. Global acetabular retroversion has been associated with hip pain, labral tears, cartilage damage, and early onset arthritis. However, due to relatively sparse literature on this topic, a detailed understanding of the pathophysiology and especially of the management remains somewhat lacking. The methods in this study involve prospective data collection, which was retrospectively reviewed for patients who underwent hip arthroscopy for FAI and labral tears between February 2008 and March 2013, who had acetabular retroversion. Acetabular retroversion was defined on a well-positioned anterior-posterior pelvic radiograph based on the presence of an ischial spine sign and a crossover sign of greater than 20%. Preoperative and minimum 10-year follow-up for the Harris hip score, non-arthritic hip score, hip outcome score, sports-specific subscale, visual analog score for pain, and the IHOT score, as well as patient satisfaction, were collected. The rates of achieving the MCID and the patient acceptable symptomatic state, or PASS, were collected, as well as hip joint survivorship from conversion to total hip arthroplasty and rate of revision hip arthroscopy. Patients with retroverted acetabulum were propensity matched in a 1-to-1 ratio to patients without a retroverted acetabulum. Non-retroverted patients were identified based on not having an ischial spine sign and not having a crossover sign of 20% or more. 149 retroverted hips met the inclusion criteria with minimum 10-year follow-up. 124 retroverted hips were propensity matched to 124 non-retroverted hips in a 1-to-1 ratio based on age, sex, body mass index, tonus grade, and lateral center edge angle. There was significant improvement in all of the patient-reported outcome scores for the retroverted group from baseline to minimum 10-year follow-up, including Harris hip score, non-arthritic hip score, hip outcome sports-specific subscale, and visual analog score for pain. In addition, favorable IHOT and patient satisfaction scores were reported at minimum 10-year follow-up for both the retroverted and non-retroverted cohorts, with the retroverted cohort actually reporting significantly greater IHOT scores than the non-retroverted cohort. Both the retroverted and non-retroverted control groups achieved high rates of MCID for modified Harris hip score of 78% in the retroverted group and the non-retroverted group. Also for the non-arthritic hip score, where the retroverted group achieved MCID at greater than 80%, and also for the hip outcome sports-specific subscale and visual analog score. Both the retroverted and the control groups achieved high rates of PASS for MHHS. In the retroverted group, that rate was nearly 85%. The retroverted cohort demonstrated significantly greater achievement of PASS for VAS compared to the control group. The 10-year arthroplasty-free survivorship was 92% for the retroverted group and over 90% for the non-retroverted group, and a Kaplan-Meier survivorship curve is seen here on the right. A similar percentage of patients in the retroverted and control groups underwent ipsilateral revision arthroscopy. In conclusion, patients with acetabular retroversion can be safely treated using advanced hip arthroscopic techniques with excellent long-term outcomes and a low rate of conversion to total hip arthroplasty. Reverse anteverting periacetabular osteotomy may be reserved only for the most severe of cases. Thank you very much, and greetings from Chicago.